Greetings. This is Graham Warren working with you on the hip hop case. This case involves surgery, hip and knee replacements at a hospital by the name of Hipkins, and presumably US based. And the hospital is seeking suggestions for operational improvements with regard to two KPIs. They operate on a 10-hour day, and they'd like to get, they have two OR tracks, each with 2 ORs, and they would like to get 6 hip and knee replacements done in each on average. They'd also like to reduce patient flow times. Reduced patient flow times are going to be helpful with regard to reducing stress and anxiety and just generally improving the well-being of patients and their family members. If we can shorten that time that they're in the facility, it's to their advantage and to the advantage of friends and family. So those are the two KPIs. The hospital is interested in the revenue that comes from 6 surgeries, or just an increased number of surgeries, and it's to the benefit of both patients, the hospital, and everybody else if we can get those flow times down. So the idea is that you want the folks to show up more or less just in time, get their surgery, head out, and sort of not congest the facility. So some information about these surgeries is provided in the case, and you can see what's entailed here. This is a hip replacement, knee replacement. Obviously, these are used with permission, these photos, incidentally, and the details are shown in the case. And there's some information about typical patients. This information was provided by Professor Khanojia, who is Director of Orthopedic Surgery at Hopkins. And the bottom line here is in a study published in 2019, he found that, according to the study, that the BMI factor of patients is a meaningful impact, has meaningful impact on the duration of the surgery. So you can see, how many cases were dealt with at various BMI intervals, underweight through morbidly obese, how many surgeons were involved in those surgeries, and then the median time ranges from 94 to 115 minutes. There's a p-value of 0.045 on that study. So there's statistically significant differences in the median operation time for these different BMI cases. He also tested the idea that physical status, as measured by these ASA categories, ASA stands for American Society of Anesthesiologists, he found that did not have a meaningful, statistically significant, when I say meaningful, I mean a statistically significant impact on surgery times. So who is getting the surgery? More women than men, more folks in the 40 to 60 bracket, and then non-Hispanic Black folks, more than some of these other race or ethnic or cultural groups. And there's further details here that you can pick through. I think I would like to just run through the basic workflow for these surgeries. So we've got 2 groups of operating rooms, and they operate in the base case completely separately. So ORs 1 and 2, let's say, in track A, and ORs 3 and 4 in track B. And 6 patients are scheduled for knee or hip replacements in each of these OR groups each day. The day starts at 7:30. Patients are scheduled to arrive every 90 minutes. And, the day lasts 10 hours, 600 minutes, ends at 5:30. And then it's possible that the last patient, if they do not get their surgery, that they have to come back the next day. And that, of course, creates significant dissatisfaction or disruption. In fact, they may be called at home rather than having to come in and be disappointed. But nevertheless, the delay to the next day is very awkward and concerning. So statistics for the different BMI categories are provided here with the mean service times. You're also getting a standard deviation of their service time. And interestingly, the standard deviations increase as the BMI category goes up. So especially in the obese and morbidly obese category, special equipment is needed, and that may have to be, brought in or adjusted or whatever, as part of the normal workflow, and that's causing delays. So particularly here for morbidly obese, there's a big bounce in the standard deviation. And you can see the percentage of procedures that are done on patients in each of these BMI categories are shown here. So interestingly, more than 50%, much more than 50% of the folks getting the surgery are overweight or heavier. Okay, so the folks come in, they're registered, they receive some pre-op prep. There's a consent process. They get sedated, they get their procedure, and then they go through a period of recovery, and then most return home the same day. Some spend the night in the hospital and then return the next day, and there are a handful of cases that have longer stays. The staff members involved here are registrars, anesthesiologists, orthopedic surgeons, and then there is some folks who do the cleanup, and they're known as the EVS pool. Okay, we'll explore that briefly when we look at the Anylogic model in the next clip. So here are the times associated with each of these activities. There's a registration step here that's very brief. Then there's preoperative prep, anesthesiology, and consent. These times were discussed with Professor Khanuja, Paul Khanuja, at the time of writing the article, but may not be reflective of actual operating times, but we're going to work with them anyway. This procedure time actually comes from his published work and his was realistic in 2019, with the level of robotics and other operational considerations in place at that time. So a mean of 100.71 is standard deviation, 8 minutes. This is now across all BMI groups. We're assuming these distributions are roughly normal, and then room turnover and setup, that's to prepare the OR for the next patient. Patients go through a recovery period and then they're discharged. Again, these may be very, very aggressive times, but we're going to just work with those. And full disclosure, I have very little medical background, so I'm absolutely incapable of, absent some research on these times, of determining which are realistic and which are not. Okay, so we're going to look at, we're going to use our 4 lenses to come up with operational improvements, process improvements for this suite of ORs. And they are the familiar utilization matter. And there we're going to consider, should we be adding things like registrars, anesthesiologists, surgeons, or EVS folks? Do we need more ORs? We also ask, does pooling matter? And in particular, we're going to look at, in our clips, video clips, whether we should pool the ORs and pool the anesthesiologists. Pooling the surgeons is a little trickier because there's a consult that precedes the surgery. And so, simply having somebody show up and then get a surgery from sort of a randomly assigned surgeon would be problematic. You need to have seen the surgeon who's going to do your surgery so that case history is in place. So pooling the surgeons, probably not possible. Our next lens is going to be to inquire, or to consider how variance hurts. And we could look at, for example, reductions in the variance of some of the workflow items and what impact that'll have on things like patient flow times and the number of surgeries per day. And then does psychology matter? And the particular focus I'm going to pursue on this one is to look at the sort of emotional well-being impact of faster patient flow times, time in the facility on patients. Right. We've also got some additional questions that the director is mulling. It's just thinking out loud about what kind of process this is. Is it a job shop, a batch shop, a line flow, continuous flow? What is the flow time ultimately going to be after all the proposals are in place? What are the bottlenecks in the base case and in the final proposal? And then also, are any of the proposed changes in conflict with the idea of fostering diversity, equity, and inclusion? Got some additional language in here that and references that may be worth considering. You've got access to a pre-built AnyLogic model. The idea behind the pre-built model is to save you the drama of having to create one of these models for yourself. Having sort of a standard model does limit the kind of analysis that we can entertain. I would argue that the model I've created for you is relatively flexible, but certainly, there are elements of some process innovations that we would not be able to consider, and that's fine. Just working with the standard model is the expectation here. And then there's a playlist of which this video is the first clip. So again, absolutely no expectation that you build your own model. If you do try and build it, expect a lot of debugging and validation to have to be done. Happy to try and support that to the best of our ability, but most of us will be working with the standard model. Right, so in the next clip, we're going to explore this model, and then we will take a look at 4 candidate improvements to reduce variance, to pool, to consider utilization changes, and the psychology piece, and then some sort of complex proposal with multiple changes, and then it'll be up to you to run with this.